Start up. Hello guys. Now in this class, let's discuss about endocrine physiology. I hope there are many students who are also attending for the upcoming exam. Now let's do endocrine physiology with clinical integrations. So let's don't keep this class only for physiology. Wherever possible, let's try to integrate it with patho and also pharma. Now, without any further late, let's start with the endocrine system. Now guys, who is the master regulator of the endocrine system? The master regulator of endocrine system is hypothalamus. So here I have shown you hypothalamus. So on the top here, this area is hypothalamus. Now we all know hypothalamus have different nuclei. Now the hypothalamic nuclei releases different hormones, and those hormones will come down to the anterior pituitary. Now please concentrate here. From the hypothalamus, GnRH is getting produced. GnRH means gonadotropin releasing hormone is getting produced, thyrotropin releasing hormone, corticotropic releasing hormone, growth hormone releasing hormone. So all these releasing hormones are coming from where? Coming from the hypothalamus. Not only the releasing hormones, please concentrate growth hormone inhibitory hormone, which is also called as a somatostatin, sir. Now the growth hormone inhibitory hormone and prolactin inhibitory hormone is also coming from the hypothalamus. Now what do these hypothalamic hormones will do? Now the hypothalamic hormones will come down to the pituitary gland. Which pituitary gland? Anterior pituitary gland. So the hypothalamic hormones, they will come down to the anterior pituitary gland, and in the anterior pituitary, whom do we have? Which cells are there? Sir, in the anterior pituitary, please concentrate, there are 5 different types of cells. Now what are these 5 different types of cells, sir? Thyrotropes, lactotropes, corticotropes, gonadotropes. Okay, so these the different types of cells were there. Now what actually happens? See, the hypothalamic hormones, they will come from above and they are going to act on these cells like lactotropes, thyrotropes, gonadotropes, somatotropes. Okay, now what happens? Now the anterior pituitary will release the appropriate hormones. For example, see here guys, now whenever, see this GnRH, gonadotropin releasing hormone. Now this gonadotropin releasing hormone, it will, see, please follow the colors. Here the gonadotropin releasing hormone is coming from the hypothalamus. Where it will act? It will act on cells called as gonadotropes. The gonadotropes are present in the anterior pituitary. Okay, now gonadotropic releasing hormone, it is coming from the hypothalamus. It will come down like this. It will act on gonadotropes. Now what these gonadotropes will do? Gonadotropes will release gonadotropic hormones like FSH and LH. Now TRH, what is this TRH? Thyrotropin releasing hormone. Now this thyrotropin releasing hormone, it will act on which cell? Thyrotropes, sir. Now these thyrotropes, now they are going to release thyroid stimulating hormone. Now in the same way, CRH means corticotropin releasing hormone. Now it will come down to the anterior pituitary, it will act on corticotropes. So that corticotropes are going to now release ACTH, adrenocorticotropic hormone. Now see here, growth hormone releasing hormone. The growth hormone releasing hormone, in the name itself, it's a growth hormone releasing hormone. Now it will come and act on the cells called as somatotropes. Now these green color cells, these are the somatotropes. Now whenever these somatotropes are acted upon by, growth hormone releasing hormone, now these somatotropes will release growth hormone, sir. Okay, but important point is, see, whenever the growth hormone inhibitory hormone, whenever it comes down into the anterior pituitary, now the somatotropes are inhibited. Now they are not going to produce the growth hormone. Okay, in the same way, the prolactin inhibitory hormone, normally all the time in a female, the hypothalamus, especially the arcuate nucleus of hypothalamus, it produces something called as prolactin inhibitory hormone. Now this prolactin inhibitory hormone, in the name itself, it's an inhibitory hormone. It will come down and inhibit the lactotropes. There are cells called as lactotropes, and those lactotropes are continuously inhibited by prolactin inhibitory hormone. So there is no prolactin in a female who is not yet delivered the baby, who is not pregnant. Okay, so normal, a 20-year-old female, 15-year-old female, do you think that she is having a breast milk secretion? Definitely not. Why? Why? Because though, yes, she is having lactotropes. She is having lactotropes, and those lactotropes are capable of producing prolactin. But why she is not lactating? Because before pregnancy, normally from her hypothalamus, who is getting released? Prolactin inhibitory hormone is continuously getting released. This prolactin inhibitory hormone inhibit the lactotropes, so there is no prolactin. Okay, now see guys, let's see like what and all we have discussed. Let's have a let's have a summary. The GnRH, that is gonadotropin releasing hormone coming from hypothalamus. It will act on which cells? Gonadotropes. Now what gonadotropes will do? It will help in production of FSH and LH, sir. Now my question to you, what do this FSH will do and what do this LH will do? Sir, FSH means follicle stimulating hormone. It stimulates the follicles. It stimulates the ovarian follicles so that now follicles will grow. Now these growing follicles, what they will do? Now the growing follicles, especially the granulosa cells of growing follicles, they will produce estrogen. So remember it for your entire life, follicle stimulating hormone is very much important for the production of estrogen. Wherever you see FSH, FSH helps in production of estrogen because follicle stimulating hormone stimulates the follicles to grow. Now these follicles will produce estrogen. Now important point, now what do this estrogen will do? Estrogen it will do its physiological effects, but the same estrogen will give negative feedback to FSH. Estrogen will down regulate the FSH. This concept is very much important, like to understand, like how we will do ovulation induction with the different drugs like clomiphene citrate. Okay, but just now what you need to know is FSH all the time helps in production of estrogen. Now what do this LH will do? Sir, LH means luteinizing hormone. Now we all know luteinizing hormone is helping in the process of ovulation. Now follicles are growing. FSH is helping in development of follicles. Now whenever the follicles are developed, there will be one follicle which is absolutely developed. That follicle is called as a Graafian follicle, mature follicle. Now LH will come. Now this LH will act on the Graafian follicle. Now this Graafian follicle will undergo rupture, releases the oocyte. So ovulation is happened. Ovulation is because of which hormone? LH, sir. Now after ovulation, yes sir, we have oocyte. There is no doubt. Oocyte is there. Now what happened to this ruptured Graafian follicle? The ruptured Graafian follicle becomes corpus luteum. Now this corpus luteum is producing progesterone. So remember, LH helps in the process of ovulation. Whenever there is ovulation, there is development of corpus luteum, which is nothing but the ruptured Graafian follicle. Now this corpus luteum helps in the production of progesterone. So all the time remember, LH helps in the production of progesterone. FSH helps in production of estrogen, sir. Okay, now estrogen down regulate FSH release. Progesterone down regulates, or progesterone gives negative feedback to LH. Progesterone gives negative feedback to LH. Okay, now having said that, TRH, sir. What is TRH? Thyrotropin releasing hormone. Thyrotropin releasing hormone acts on thyrotropes. Now what these thyrotropes will do now? So the thyrotropes which are present in the anterior pituitary, now they will release thyroid stimulating hormone. Now the thyroid stimulating hormone, where it will come? The thyroid stimulating hormone will come to the thyroid gland. Now TSH will act on the thyroid gland. So the thyroid gland, the follicular cells of thyroid gland is going to produce T3 and T4, our thyroid hormones. Now GHRH means growth hormone releasing hormone. It is acting on somatotropes. Somatotropes are going to release growth hormones. Now what do this growth hormone will do? Growth hormone is going to act on your body viscera, also going to act on your bones, so that increases the growth, increases the size of the cells, increases the size of the tissues, not only the bones but all the viscera. Okay, now what is the CRH? Corticotropic releasing hormone. Corticotropic releasing hormone acts on corticotropes. Now what do these corticotropes will do? So the corticotropes will release ACTH, adrenocorticotropic hormone. Now this adrenocorticotropic hormone will come to adrenal gland. Now this adrenal gland will release glucocorticoids like cortisol. Now the last one, prolactin inhibitory hormone, which is all the time coming from the hypothalamus, which is an inhibitory signal. Inhibitory signal to which cells? Lactotropes. So the lactotropes are inhibited now. Now these lactotropes, do you think are they going to produce prolactin? Now they won't produce prolactin. Okay, till the time there is prolactin inhibitory hormone, there is no prolactin. But when the female become pregnant, now what happens? Especially after delivery, the prolactin inhibitory hormone is going to be suppressed. There is no prolactin inhibitory hormone. Now the lactotropes are activated, sir. Now the lactotropes, they will start to produce prolactin. And what is this prolactin doing? It helps in galactopoiesis. Okay, it helps in milk production, sir. Okay, see, milk production is under the control of hormone prolactin. Lots of times this question was asked. Prolactin helps in milk production, that is galactopoiesis. But if they mention the word galactokinesis, that is milk ejection. Galactokinesis is because of which hormone? Oxytocin. But galactopoiesis is because of prolactin. Okay. Now, having said that, hope you had a better understanding of how all these axes will work. Okay. Now, what is the highermost center? It's the hypothalamus, sir. Hypothalamic hormones coming to anterior pituitary. Anterior pituitary will release growth hormone, thyroid stimulating hormone, ACTH, FSH, LH, prolactin. Now, these hormones will act on their particular organs so that appropriate response will be, appropriate response will come. Now, after this, let's talk a few important points about the prolactin inhibitory hormone. Okay, prolactin inhibitory hormone. Now, what exactly is this prolactin inhibitory hormone? We have discussed, guys. Prolactin inhibitory hormone is coming from hypothalamus. The prolactin inhibitory hormone is nothing but, remember, it's nothing but dopamine. Okay, now dopamine, which is coming from the hypothalamus, will inhibit the prolactin. So we can say prolactin and dopamine, they are antagonistic hormones. The prolactin inhibitory hormone is nothing but the dopamine. Dopamine will suppress the prolactin. So both are antagonistic hormones. Okay, guys, is it clear? See, someone is asking, estrogen and progesterone, it can also make inhibition of GnRH in hypothalamus? Yes, absolutely. Okay, now estrogen, what it will do? Estrogen will downregulate. Whenever there is sufficient amount of estrogen, now this estrogen will downregulate FSH and downregulate the hypothalamus also. Okay. Now, let's go further. Now, let's talk about something called as the acidophilic cells in the anterior pituitary. Guys, how many types of cells are there in the anterior pituitary? I have clearly shown you there are 5 different types of cells were there. There are 5 different types of cells: corticotropes, lactotropes, thyrotropes, somatotropes, gonadotropes. 5 different types of cells are there. Now, whenever you stain them, okay, whenever you do staining, especially 2 groups of cells will take the red color stain or the eosinophilic stain. Now, those cells are called as the acidophilic cells, acid-loving cells. Now, which cells are acid-loving cells, sir? The somatotropes and lactotropes are considered as the acidophilic cells. Now, they will produce which hormones? Sir, somatotropes are going to produce growth hormone and prolactin is coming from the lactotropes. Now, these 2 hormones are considered as the twin hormones. Okay, the growth hormone and the prolactin, they are considered as which hormones? Twin hormones, sir. Now, why do we are calling it as a twin hormone? Because, see, both the growth hormone and the prolactin, they will use same type of receptor. They will use same type of cellular signaling for their actions. Just wait a minute, I will explain you. See, guys, here, now what I am saying is, the growth hormone and prolactin, they use same types of receptors. Which receptor, sir? If you ask me, I will give you a mnemonic. Sir, see, the mnemonic which I am going to give you here is, sir, PIG, pig hormones. Just a mnemonic. The P for prolactin, I for insulin, and G for growth hormones. So, prolactin and growth hormone. Prolactin here and growth hormone. They use which type of receptor, sir? Both of them, they have tyrosine kinase receptors. So, both growth hormone and prolactin, they are coming from the acidophilic cells and they are considered as the twin hormones because they use one single type of receptor, that is tyrosine kinase receptor. Okay. Now, after this, let's talk about a question which was asked in the exam. Inhibitory control by the hypothalamus is shown on which cells? Inhibitory control. Normally from the hypothalamus, releasing hormones are coming. But there are also inhibitory hormones. What are they? Somatostatin as well as prolactin inhibitory hormone. So, somatostatin and prolactin inhibitory hormone, which is nothing but dopamine, they will inhibit growth hormone production as well as prolactin. So growth hormone is getting inhibited, prolactin is getting inhibited. So hypothalamus is exerting inhibitory control over these two hormones. It's a true statement. Okay. Now dopamine is coming from which nucleus? This was also a question which was asked in the recent exams. So dopamine is coming from the hypothalamus from a nucleus called as arcuate nucleus. The arcuate nucleus of hypothalamus releases dopamine. Now, after understanding this, let's understand a clinical scenario, guys. Clinical scenario. Now, what I am showing here is, sir, on the top there is hypothalamus and down there is pituitary gland, anterior pituitary and posterior pituitary. Now, what happens exactly here is there is a damage to the pituitary stalk. Normally here pituitary stalk was supposed to be there, but now in our condition what happened is there is a damage to pituitary stalk. Might be the patient is going, like, the person was going on a motorcycle, he had a road traffic accident, he had a trauma to his head. Now during the trauma what happened is the pituitary stalk got dissected. Now what will happen to the hormones? See, now usually from the hypothalamus, usually releasing hormones are coming to the anterior pituitary. Now there is no connection between hypothalamus and anterior pituitary. Now what happened to growth hormone, sir? Growth hormone levels are coming down. Why? Because there is no growth hormone releasing hormone. There is no growth hormone releasing hormone. Now whenever there is no stimulation, to the somatotropes, now growth hormone is not going to be there. Now TSH will come down because from the hypothalamus there is no thyrotropin releasing hormone. TRH is not coming down. So all the releasing hormones are not coming from the hypothalamus. So what happened? FSH will go down, LH will go down, ACTH will go down. But what happened to prolactin? Sir, prolactin's levels increases. Now why prolactin level increases, sir? Prolactin level increases because now from the hypothalamus, do you think prolactin inhibitory hormone is coming down to the anterior pituitary? No, because the pituitary stalk got damaged. The prolactin inhibitory hormone, the inhibitory control on the lactotropes is lost. So now the lactotropes are functioning, they will produce prolactin. So just tell me, whenever the pituitary stalk is damaged, which hormone level goes up? Prolactin level goes up. Okay. Now after this, let's talk about one more scenario where the pituitary gland here, the pituitary gland what I am showing you, the pituitary gland got totally damaged. There is a necrosis of the pituitary gland. Both the anterior pituitary and the posterior pituitary got totally damaged. Now you can ask me, why the pituitary gland is getting damaged, sir? Total necrosis. See, there is a condition called as a clinical syndrome called as a Sheehan's syndrome. Okay. Now what exactly is this Sheehan syndrome? To understand that, let's start from here. Imagine that there was this one female who is pregnant. Okay, who is pregnant. During pregnancy, the pituitary gland will double in its size, almost 136% increase in the size of the pituitary gland. Just think like this, during pregnancy, to supply the demand, the pituitary gland is going to increase in the size. Whose pituitary gland? Mother's pituitary gland is going to become big in size. Now, just tell me, now this big pituitary gland, does it demand more blood or not? Yes, sir, definitely it will demand more blood. Okay, but right now what is the problem is, she delivered the baby. Now during delivery, a small problem has occurred. What is that? Now the patient, now this mother is suffering with postpartum hemorrhage. Now the mother is suffering with postpartum hemorrhage, sir. Now what is postpartum hemorrhage? Now she is bleeding like hell. She is bleeding. Now she have lost almost 1 liter of blood or 1.5 liters of blood. Now what will happen? There will be a compensatory mechanism which is going to happen in the mother, that is vasoconstriction. Whenever she is losing lot of blood, immediately the mother's blood vessels, they will undergo spasm, they will undergo vasoconstriction. Now they are undergoing vasoconstriction. What will happen to the pituitary gland? Now even the blood vessels which are going to the pituitary gland, they have also undergone spasm. Now tell me, mother's pituitary gland is big in size. It is demanding more and more blood. But what is happening to the blood vessels? The blood vessels are undergoing constriction, sir. So what happened to the blood supply to the pituitary gland? The blood supply to the pituitary gland is greatly compromised. So the pituitary gland will suffer with ischemia, hypoxia, later necrosis will happen. So when necrosis is happening, there is postpartum after the delivery. Whenever there is severe hemorrhage, that is postpartum hemorrhage. Now, in those conditions, the pituitary gland will undergo necrosis. So, this is called as a postpartum necrosis of pituitary gland, which is also called as the Sheehan's syndrome. Now, tell me, in Sheehan's syndrome, what happens? Entire pituitary gland is gone. When entire pituitary gland is gone, all hormone levels comes down. So, all growth hormone, TSS, FSH, LH, ACTH, and even prolactin levels are also coming down, right? Because the entire pituitary gland is gone. Okay, so even prolactin levels are also comes down. All hormone levels comes down. Okay, guys, is it clear? Everything is clear, guys? Pandit, Osama, Abdi Nasir, is it clear? Shall I continue? Okay, so I have explained to you the two different clinical scenarios. One is the Sheehan syndrome and the other is the pituitary stalk damage to pituitary stalk. Okay, now let's talk about a few more important concepts which you need to know for your pharma also. Okay, for your pharma, especially this is important for the exam going students. Normally, sir, here see, here is the hypothalamus. This is hypothalamus. Okay, now hypothalamus is having a nucleus which is producing the GnRH, that is gonadotropic releasing hormone. Now this gonadotropic releasing hormone, we know it will come down to the anterior pituitary. It will come down to the anterior pituitary and it will act on gonadotropes. So that gonadotropes are releasing FSH and LH. But here the important concept which I want you to know is normally, sir, normally the GnRH whatever is coming down, it will come down in pulsatile doses. GnRH, it will come to the anterior pituitary, it will act on gonadotropes in a pulsatile doses. Pulsatile doses means not continuously, in a regular intervals. GnRH is coming, stimulating the gonadotropes so that there is FSH and there is LH. Now, whenever this is happening in a physiological way, yeah, definitely FSH production is going to be there, LH production is going to be there. But whenever you have a continuous stimulation, continuously, for example, because of some reason, from the hypothalamus, GnRH is coming down continuously. Now, whenever there is continuous stimulation, the receptors will undergo desensitization. Continuous stimulation is bad. Now, whenever there is a continuous stimulation, see, continuous GnRH causes desensitization of the receptors. So, what happens is FSH will go down, LH hormone levels will go down. Now, you can ask me, sir, why you are explaining this concept? It's because by understanding this concept, you can actually treat the patients, you can actually treat certain disorders. Now, let's talk about the clinical importance. Okay, see guys, just give me 1 minute. Yeah, now, so GnRH, normally GnRH, that is gonadotropin releasing hormones. Now, we have what happened? I think it will come. Just guys, 1 minute. There is a small issue. Just check. Okay guys, the problem is resolved. Now, see, normally in the pharmacy, we have manufactured drugs which are acting like GnRH. Now, what is GnRH? Gonadotropin releasing hormone. Now, can you name some drugs which are GnRH analogues? What are the GnRH analogues, sir? The GnRH analogues include, see, these drugs: leprolide, nafrelin, goserelin, buserelin, the drugs which are ending with the name relin. So, these drugs are GnRH analogues. Just know this one point. Sir, GnRH is something produced inside the body, but in pharmacy, in the pharmacological industries, we can make drugs similar to GnRH. Examples are leprolide, goserelin, buserelin, nafrelin kind of drugs. Now, see, now you can use these drugs either in pulsatile doses, or you can use these GnRH analogues even in continuous doses. Now, when we will use these drugs in pulsatile doses, and when we are going to use these drugs in a continuous doses? Now, see, sir, you should use these GnRH analogues in a pulsatile dose to treat delayed puberty. Now, I am asking you, what exactly is delayed puberty? It's very simple. Imagine like this. There was this one female. Now, she is almost 16 years old. Now, she is 16 years old. Normally, a female should have to start her menstrual cycle somewhere around 13 years or 14 years. But now she got 14 years. Still, she is not having her cycles. Okay, she is not having her menstrual cycles. Now, she is not having breast development, which means she haven't attained her puberty. Now, there is no FSH in her body. There is no LH in her body. Now, what we have to do as a doctor? As a good doctor, we have to use GnRH analogues in a pulsatile dose. Now, what you are giving to this patient is, you are giving GnRH analogues in a pulsatile dose. Now, whenever you give this GnRH analogues in a pulsatile dose, these GnRH drugs, what they will do? They will go to the anterior pituitary. Now, they will stimulate the gonadotropes so that there is release of FSH as well as LH. Now, what FSH will do in this female? Now, the FSH will stimulate the follicles to grow. And what LH will do? LH will help in ovulation. Now, whenever there is FSH and LH, now she is going to have her menstrual cycles. Very simple. So, for the treatment of delayed puberty, what you have to use? You have to use GnRH analogues in a pulsatile dose or continuous dose. You have to use them in a pulsatile doses. And when a female, whenever she is suffering with anovulatory infertility, very common in India, very common. And not only in India, in the world, the most common cause of infertility is anovulation. PCOS, there is the disease called as polycystic ovarian syndrome. If a female is having polycystic ovarian syndrome, now she won't ovulate. Whenever she is not ovulating, do you think she will become fertile? Do you think she will become mother? Definitely not. Now, what you have to do? She is not releasing the egg, sir. Now, what you have to do as a doctor is, you have to make her release the egg. You have to make her ovulate. Now, what you will do for this condition? Again, same thing, GnRH analogues in a pulsatile dose. Whenever you give GnRH analogues in a pulsatile dose, now these GnRH analogues will go to the anterior pituitary, stimulate the gonadotropes. Now, gonadotropes will release the LH, FSH as well as LH. Now, what LH will do? LH will help in ovulation, sir. Her main problem is anovulation. Now, you make her ovulate. Problem is solved. She is going to become fertile again. Okay. Now, next thing is Turner syndrome. Normally in Turner syndrome, just think logically and tell. The Turner syndrome, the patient is having hypogonadism. Now, she is not having estrogen in her body. Turner female. What is the main chromosomal abnormality in Turner female? The main chromosomal abnormality in Turner female is 45X0, which means one X chromosome is lost, 0, X0. Now, answer my question. Sir, she is not having proper ovaries. Now, whenever the proper ovaries are not there, no follicles are getting matured. Whenever the follicles are not getting matured, there is no estrogen. The main problem, you know what happens here? Whenever there is no estrogen, her bones will become brittle. She will suffer with osteoporosis. Remember, for your entire life, in girl's body and a woman's body, estrogen is osteoprotective. Estrogen helps in development of bones. Estrogen prevents the osteoporosis. Now, in this female, Turner female, now estrogen is not there. Whenever estrogen is not there, now what happens? She will suffer with osteoporosis. A 15-year-old girl, a 20-year-old girl, now she is having bone pains, osteoporosis, easy fractures. Now, what you have to do? Give her GnRH analogues in a pulsatile dose. Now, these GnRH analogues will stimulate her pituitary gland to release more and more FSH. Now, this FSH will stimulate whatever the ovaries were left over. It will stimulate the ovaries in such a fashion that there will be estrogen production. Okay. So, This is one way of giving GnRH analogues, that is a pulsatile doses. You can use GnRH analogues in a pulsatile dose. Now you can also use GnRH analogues in a continuous dose. Continuous dose means suppression. Whenever you give GnRH analogues in a continuous doses, there will be suppression of the entire hypothalamo pituitary ovarian axis or gonadal axis. Entire axis will come down. Entire axis will be inhibited. Now see, in which conditions we are going to use this? Sir, whenever a female is suffering with precocious puberty, okay, whenever a female is suffering with precocious puberty, what does it mean by? By just 8 years, now she is starting her menstruation. Just by 7 years, she is starting her breast development. Is that good for that female? Now that female is not ready for menstruation. Her body does not support menstruation. So as a good doctor, what you should do? You have to immediately stop menses in this female. So for that, give the GnRH analogues in a continuous fashion. Whenever you use continuous fashion, gonadotrope stops producing FSH, LH. So FSH will come down, LH will have come down. Whenever there is no FSH and whenever there is no LH, it's not possible, guys. Menstruation is not possible. So you have inhibited the ovulation. Okay, you have inhibited the menstruation. And in the conditions like endometriosis. Now what exactly is endometriosis? And to understand this, see, endometriosis is growing of endometrium outside the uterine cavity. Growing of endometrium outside the uterine cavity. For this condition, see, for the endometriosis to happen, estrogen is very, very important. Estrogen is the very important risk factor for endometriosis. Now what you should do as a good doctor? As a good doctor, you have to decrease the estrogen. Whenever you decrease the estrogen, automatically endometriosis, the problem of endometriosis will also come down. So what you have to do? Give GnRH analogues in a continuous dose. FSH will come down, so that estrogen will come down. Whenever estrogen is coming down, the ectopic endometrium, whatever is there, it will undergo atrophy. So it can be used for the treatment of endometriosis, true. And in the breast cancer, normally the most important risk factor for breast cancer is estrogen. Now what you have to do? Whenever there is high estrogen levels in this female, for example, imagine that there was this one female who is having a breast cancer. Now the estrogens in her body will support the growth of cancer. Now what you have to do? You have to decrease the estrogen levels in this female. Now whenever you decrease the estrogen levels in this female, the size of the cancer will come down. Okay, the size of the cancer will come down because estrogen is the stimulant. Estrogen is like a growth hormone. Estrogen is like a growth hormone or nutrition for the cancer. What you have to do? You have to decrease the estrogen levels. How you can decrease the estrogen levels? Simple. Give GnRH analogues in a continuous dose. Whenever you give GnRH analogues in a continuous dose, FSH will come down. When FSH is coming down, automatically estrogen will come down. When estrogen comes down, the problem is partially solved. Okay, for breast cancer, definitely you have to go for the modified radical mastectomy. Okay, the patient should have to go for the mastectomy, surgery. But before surgery, you have to decrease the estrogen levels in her body by giving GnRH analogues in a continuous doses. Okay, these are the important points which I want you to know. Guys, is it clear? Is it everything clear? So definitely after the class, all with all the annotations, we will provide you the PDF. Last time, I just forgot to save the PDF so that I couldn't able to give the PDF for the gynae classes. So this time, the entire endocrinology PPT will be given to you in the group, in the Telegram group. Okay. Okay. Okay, guys. Now, after discussing this, now let's also talk about the posterior pituitary. So far, what we are discussing is about the anterior pituitary. Now, let's talk about the posterior pituitary. So, we all know posterior pituitary is releasing which hormones? Posterior pituitary is releasing oxytocin as well as antidiuretic hormone. But my question is, see, posterior pituitary is not producing the antidiuretic hormone. Posterior pituitary is not producing the oxytocin. Then who produces? Sir, it's again hypothalamus. Okay, hypothalamus produces the antidiuretic hormone and the same hypothalamus produces the oxytocin. Even renal physiology, I have explained this. So, the supraoptic nucleus of hypothalamus, the mnemonic is supraoptic nucleus of hypothalamus produces the antidiuretic hormone and the paraventricular nucleus, PVH means PVN, it's the paraventricular nucleus of hypothalamus produces oxytocin. Now question, from where do these hormones are getting produced? From the hypothalamus, sir. From the hypothalamus. And now where they are getting stored? Now these hormones are getting stored in the posterior pituitary, posterior pituitary. So never ever say that posterior pituitary is synthesizing antidiuretic hormone or oxytocin. Synthesis is all the time happening in the hypothalamus from supraoptic nucleus as well as paraventricular nucleus. Done. Simple. Now the questions which will come in your exams, especially the Indian exams, is, sir, now this oxytocin and especially the antidiuretic hormone, they are stored in the vesicles. They are actually stored inside the vesicles. Now what is the name of these vesicles? The name of these vesicles are called as the Herring bodies. So Herring bodies are the storage sites for antidiuretic hormone. True. These are just the vesicles which are packed with the hormones. Now let's see some important points regarding the oxytocin and antidiuretic hormone. Now what is the function of the oxytocin, sir? What do this oxytocin will do? Sir, oxytocin, it helps in uterine contractions. During delivery, first phase and the second phase of delivery, the baby have to come out of the uterus, right? Now, uterus will contract, uterus have to contract. Now, which hormone makes the uterus to contract? It's the oxytocin, sir. That's the one thing. And the second important point about the oxytocin is, sir, oxytocin after delivery, it will act on the breast. It will act on the breast so that the milk, whatever is already produced in the breast, it will eject out, it will come out. So milk ejection or galactokinesis is done with the help of oxytocin. So uterine contraction, one function, and second function is milk ejection. And the same oxytocin, we can use it as a drug. Okay, we can manufacture the oxytocin in the pharmacy, in the industries, and we can use this oxytocin for certain conditions, guys. Now what are those conditions? Oxytocin is used as a drug of choice for which condition? Sir, postpartum hemorrhage. Now what exactly is postpartum hemorrhage? Just a brief idea. Sir, normally think like, okay, even though if you are a first year students or like exam going batches, I'm just asking you what exactly is postpartum hemorrhage. So normally during vaginal delivery, a female is delivering. Delivery is happening normally, normal birth, NVD, normal vaginal birth. Now my question is, how much will be the blood loss? So during normal vaginal delivery, 500 will be the blood loss. 500 ml of blood will be lost from the female body. Whatever you do, usually 500 ml or just normal less than 500 ml blood will be lost. But in a normal vaginal delivery, if there is loss of more than 500 ml of blood, that is called as postpartum hemorrhage. Normally during C-section, okay, you are cutting. Now whenever during C-section, normally 1000 ml of blood will be lost. But during C-section, if there is loss of more than 1000 ml of blood, that is called as postpartum hemorrhage. After delivery, there is hemorrhage. Okay, more than 500 during NVD, normal vaginal delivery, and more than 1000 after a C-section. This is postpartum hemorrhage. Now, can you tell me what is the most common cause of postpartum hemorrhage? Why there is hemorrhage happening from the uterus? It's because the uterus is not contracting. Normally after the delivery of the baby, see, normally after the delivery of the baby, uterus have to contract. Okay, uterus have to contract and throw the placenta. Now, uterine contractions will close the bleeding blood vessels. Remember, now uterus will contract and ligate the bleeding blood vessels. But for example, think now what happens if the uterus is not contracting? Simple bleeding is happening, sir. Simple blood loss. So this is called as atonic uterus. So atonic uterus is the most common cause of postpartum hemorrhage. Postpartum hemorrhage. Now what you have to do as a good doctor? So now you have to make this uterus contract so that give her a bolus of oxytocin. So oxytocin is used as a drug of choice to treat postpartum hemorrhage. Okay, to treat postpartum hemorrhage, you have to use oxytocin. And now the female is suffering with a condition called as the breast engorgement. Now what is breast engorgement? Now a female is producing the milk in her breast, but that breast is not coming out. So breast is getting engorged with the milk. Milk is not coming out. Okay, now she is having a very tight, firm breasts. Milk is there, but it's not coming out. So now what you have to do? Simple oxytocin. Now whenever you give oxytocin, what happens? Now oxytocin will let the milk out, will cause milk ejection. So for breast engorgement also the drug of choice is oxytocin. And for induction of labor. So what exactly is induction of labor? Now a female, she is already in term. Okay, now she is in term, but she is not going into labor. She is not going into labor. Her term is completed. 9 months is completed. Now she is not going into labor. Now what you have to do? You have to kickstart the labor. You have to start the labor. Okay, so the starting is called as induction. So how you have to start her labor? Now if you want a female to go into labor, just give her injection of oxytocin. Definitely now she will go into labor. So for the induction of labor, what is the drug of choice? Again oxytocin. Now, so after discussing about oxytocin, now let's talk about the importance of vasopressin. The vasopressin is also called as antidiuretic hormone. Now this antidiuretic hormone, where it will act? The antidiuretic hormone. The antidiuretic hormone will act on V2 receptors in the collecting ducts. In the nephron, there are cells called as the principal cells. Now on these principal cells, V2 receptors are present. Now antidiuretic hormone, it will come and it acts on V2 receptors. Now whenever the V2 receptors are activated, stimulated, now these principal cells, they will synthesize this new channels called as aquaporin 2 channels. Now what happens? Now water reabsorption happens. Now antidiuretic hormone, so whenever there is antidiuretic hormone, the antidiuretic hormone acts on V2 receptors on the collecting ducts, so that now aquaporin 2 channels, they will start to reabsorb water. So the name itself is there, antidiuresis. So decreasing the amount of urine. So antidiuresis. Why? Because most of the water is being reabsorbed with the help of aquaporin 2 channels. Okay. Now important point which I want you to know is, most of the student knows this one thing. Sir, vasopressin acts on V2 receptors. Every student knows this. Sir, but also important point, the V2 receptors are not only present in the collecting ducts, not only present in the nephrons, but the V2 receptors are also present in the vascular endothelium. V2 receptors are also present on vascular endothelium, means inside the blood vessels. Now the V2 receptors are present inside the blood vessel. Now whenever you stimulate this V2 receptor, what happens? Now sir, what happens is the von Willebrand factor was released from the endothelium. Okay, let me show you something like this. See, it's very simple. Now, see, think this is the blood vessel. Okay. Now, inside the blood vessel, what is the lining present? The lining present, this is the lining, sir. This lining is the endothelium. Now, on the surface of this endothelium, which receptors are present? Again, V2 receptors are present. Now, whenever you stimulate this V2 receptor, now these endothelial cells, they will release von Willebrand's factor. Von Willebrand's factor. Von Willebrand factor, we all know it helps in platelet adhesion, platelet aggregation. Later on, coagulation cascade will happen, so that clots will form, helping clot formation. Okay, so these are the important points which I want you to know. So V2 receptor, two important places. What are the two important places of V2 receptors? Close your eyes and tell me, sir. The V2 receptors are present on the collecting ducts. V2 receptors are present on the collecting ducts, helps in water reabsorption. The same V2 receptors are also present on vascular endothelium. Now vascular endothelium is releasing von Willebrand factor, help in platelet adhesion, platelet aggregation. Now there are receptors called as V1 receptors. Now where do these V1 receptors present? Not inside the blood vessel, sir, on the surface of blood vessel. On the surface of blood vessel, smooth muscle is there, right? So on the smooth muscles of blood vessel, you have this V1 receptor. When you stimulate this V1 receptor, the blood vessels will undergo constriction. That is the reason why the antidiuretic hormone is also called as vasopressin. It presses the blood vessel. It causes the constriction of blood vessels. So V1 receptor is present on the blood vessels. V2 receptor is present in the blood vessels on the endothelial cells. Okay, so I have explained you whatever is needed. Now, guys, shall I go forward? Shall I go forward, guys? Is it clear? Everyone, is it clear for everyone? Someone is asking, sir, aren't aquaporin 2? See, it's aquaporin 2 channels are going to come to the luminal surface. Okay. Now aquaporin 2 channels, they will come and they will be implanted on the luminal side, so that water reabsorption will happen. They will come to the luminal side. Okay, not the basolateral side. Yes, apical side or the luminal side. Apical side or the luminal side, they are implanted, and water reabsorption happens under the influence of antidiuretic hormone. This type of water reabsorption is called as solute-free water reabsorption. Only water is getting reabsorbed, no sodium, no potassium, nothing is getting reabsorbed. Only water is getting reabsorbed. This is solute-free water reabsorption, also called as facultative water reabsorption. Facultative, why? Because with the help of a hormone, see, with the help of antidiuretic hormone, water is getting reabsorbed. Okay. Now, after this, also we have discussed about the ADH receptors. Now we are done. Now let's start about the first hormone in the endocrinology, that's the growth hormone. Okay, the first hormone which we are going to discuss right now is about the growth hormone. Now, the kind of questions which will come in your exam and the important concept which you need to know are, sir, growth hormone production is increased by, in which condition growth hormone is going to be increased, and in which condition the growth hormone production will go down. This is what you have to know for your exam. Sir, think like this, growth hormone, it will cause the growth, no doubt. And all those conditions, whenever you need glucose, all those conditions, whenever you need glucose, in all those conditions, growth hormone is released, and growth hormone, remember, it increases the blood glucose levels. So growth hormone is going to increase it in those states whenever you need glucose. If you know this concept, it will be very much easy. Now everything is going to be down the hill. See, just think like this. Sir, during fasting, what happens to your blood glucose levels? Your blood glucose levels are going down, sir. Now, do you need glucose or not? You need glucose. So now what happens? Do you know? Growth hormone is going to be released. Now this growth hormone acts on your liver, causes glycogenolysis. So glycogen is getting broken down into glucose. So try to understand like this. So during fasting, you need glucose, sir. So growth hormone will come and increases the blood glucose levels. Most of the students, what they will think is only glucagon will increase the glucose. Sir, insulin, every student knows insulin will decrease the glucose, glucagon will increase the glucose. Students know this. But also remember, not only glucagon, also our growth hormone increases the blood glucose levels. Okay. Now, during exercise, do you need glucose or not? Yes, you need glucose. So growth hormone production increases. So during exercise, growth hormone production increases. Growth hormone increases the glucose. That glucose is utilized by the muscles for their activity. And during trauma, the trauma can be anything. Think like this. There can be psychological trauma, there can be physical trauma, there can be microbiological trauma, anywhere. So during trauma, your body needs more glucose for the repair. Okay. So during traumatic states or during stress states, growth hormone production is going to be more. Growth hormone increases the blood glucose levels. Okay. Now, whenever your blood glucose levels are going down, it's very common thing, right? Whenever your blood glucose levels are going down, glucagon increases as well as growth hormone level increases. Now ghrelin, sir, ghrelin is going to be seen during which states? During fasting states, ghrelin is going to be produced, ghrelin is going to be released. This ghrelin will go to the brain, the ghrelin increases the levels of growth hormone in the blood. Okay. Now glucagon, every student knows, sir, glucagon increase the blood glucose levels. No, true, but glucagon and growth hormone are friends. Glucagon will go to the brain, increases the growth hormone levels. Growth hormone again it will come down, increases the further increases the levels of glucose. Now arginine, the amino acids like arginine, and especially sleep, sir. Sleep, which sleep? NREM 3 and 4. Put 5-star marks here. This is a repeatedly asked MCQ. Repeatedly asked. Sir, there are actually two sleeps. NREM sleep, non-rapid eye movement sleep, as well as REM sleep. NREM sleep, REM sleep. Important point which I want you to know is, sir, NREM 3-4 is called as a deep sleep. Delta waves are seen in ECG. Not ECG, EEG. Delta waves are seen in EEG. NREM 3-4 are deepest sleep, sir. Now during this NREM 3 and 4, now growth hormone levels are increased. But during REM sleep, rapid eye movement phase sleep, during REM sleep, growth hormone levels are going down. So if someone comes to you and asks you, during sleep, what happened to growth hormone levels? Sir, now you have to ask them, during NREM or during REM? During NREM 3 and 4, growth hormone levels are increased. During REM sleep, growth hormone levels will go down. Here itself, I just want you to know one more important point. Sir, during REM sleep, growth hormone is coming down, no doubt. But who will increase, sir? During REM sleep, prolactin levels are increased. Remember that point. During REM sleep, prolactin levels are elevated. Okay, anyway, now let's continue. So the testosterone. Testosterone is a male sex corticoid. So testosterone, just think like this, for the sexual activity, do you need glucose or not? Yes, you need glucose. So testosterone increases the growth hormone increases the glucose. Okay, and estrogens, both testosterone, estrogen, they are sex hormones. For the sexual activity, you need glucose. So think like this, okay, so for sexual activity, you need to have the glucose. So growth hormone will come, growth hormone increases the glucose, so you can have your sex. Simple. Okay. But now growth hormone is decreased by, we all know one thing, somatostatin. Somatostatin are also called as the growth hormone inhibitory hormone, decreases the growth hormone levels, we know. Along with that, I have already explained to you, sir, during REM sleep, growth hormone levels are going to come down. Okay, growth hormone levels are going to come down. Just know these 2 points, just know these 2 things which are enough for your exams. Okay. Now, is it clear, guys? Shall I go forward? Is it clear? If you have any doubts, you can all the time ask here in the. So okay, let's go forward. Now, let me discuss about the actions of growth hormone. Let me discuss about the actions of growth hormone. Now, what do this growth hormone is doing in our body? First important point what I want you to know is, see, so first growth hormone. Growth hormone, is it an anabolic hormone? It is a catabolic hormone. Growth hormone, it anabolic hormone, sir. It's an anabolic hormone. It's not a catabolic hormone. It doesn't destroy anything. It's an anabolic hormone. It helps in growth of the body. It's an anabolic. It helps in, it promotes the growth. Okay, so now what it is doing? Normally, let's start from here. At this point, from the anterior pituitary, somatotropes are releasing the growth hormone. Now this growth hormone, what it will do? Sir, growth hormone, it will come to the adipose tissue, it will come to the muscles, and it will also go to the bones. Now what growth hormone do to the fats? The growth hormone will cause lipolysis. So the lipids are going to be broken down. Unnecessary lipids are going to broke down. But whenever I'm talking about the proteins, see sir, what is happening with the proteins? Proteins are getting increased. So it's making your body in a very handsome way, a beautiful way. So the extra fats, whatever were there, so the extra fats, all those fats are going to be burned down, but the muscle, the lean body mass, the muscles are going to be increased. There is protein synthesis with lipolysis. And what it is doing to the bone? Directly, sir, the growth hormones directly. The growth hormone will act on the bones, you know, especially on the epiphyseal plates, the bone growth will be there. Okay, so these are the direct actions. One important point which I want you to know is directly, see, growth hormone, the direct action is lipolysis, the major action. Now the same growth hormone, whenever it's acting on the liver, see, whenever it goes through the liver, now do you know what happens? Now the growth hormone, now see, two important points I want you to know. Sir, growth hormone, it stimulates the glycogenolysis. Means whatever the glycogen which is there inside the liver, that glycogen will be broken down. The glycogen will be broken down so that glucose levels will increase the blood. Now, my question, sir. See, whenever your growth hormone level increases too much, now that growth hormones will increase your blood glucose levels. Also, many folds increase in the blood glucose levels. So, whenever there is more glucose levels in your blood, so can I say that you are suffering with diabetes? Yes, absolutely, diabetes mellitus. You are suffering with diabetes mellitus. So growth hormone, is it causing diabetes or not? It is causing diabetes. It is increasing the risk of diabetes. In a normal person, it will never happen. In a person who are having excessive growth hormones, now they will suffer with this diabetes. So growth hormone is called as diabetogenic hormone. In excessive quantities, it increases the blood glucose level so much that the patient can go actually into diabetes mellitus. Okay, now after this, what else you should know? So the growth hormones in the liver, they are converted into something called as a somatomedians or somatomedian C, which is also called as insulin-like growth factors. Growth hormones, whenever they are passing through the liver, they are actually converted into substances or the chemicals called as a somatomedian C or insulin-like growth factor 1, ILGF1. Now see, just tell me, sir, this ILGF or somatomedian is nothing but growth hormone, right? It just simply changed its form. It's changed its form. Now what is the function of the somatomedian C? Again, sir, see, this is an indirect action. So somatomedian C, it will again come and acts on the bone, and again it causes growth. So what I am trying to put into your mind is, sir, growth is happening in how many ways? There is a direct way and there is an indirect way. There is a direct way, indirect way. Direct way is directly growth hormone is acting on the bones. Indirect way is the growth hormones are going to be converted into the somatomedians, and the somatomedians will act on the bone, helps in the growth. So direct and indirect. Okay. Now why I am so specific about this is because there is a syndrome where the indirect pathway is gone, so that the person will develop dwarfism. Later I will explain to you. So just know, growth hormone will be converted into somatomedian C. But one more important point which I want you to know is, so the somatomedians, they are anti-lipolysis. They are causing anti-lipolysis. Normally, growth hormone, what is the direct action of growth hormone? So the direct action of growth hormone is lipolysis. They will burn down the extra fats, lipolysis. But the somatomedian C or the insulin-like growth factor in an indirect way, they will cause anti-lipolysis. Know this one point. Okay. Growth hormone, lipolysis. Somatomedian C, anti-lipolysis. Now, the answer, see, this is the reason why I'm just repeating so many times. Growth hormone, it helps in bone growth. Via direct action or indirect action? Via both the direct as well as indirect actions. Direct action means direct growth hormone is acting on the bone. Indirect action means via insulin-like growth factor 1 or somatomedian C. Now, after this, let's talk about now abnormalities of the growth hormone production. Now, for example, whenever you are having excessive amount of growth hormone, okay, excessive amount of growth hormone, when sir? Now, excessive amount of growth hormone is there during childhood, in a childhood. Now, we all know childhood, the children, their epiphyseal plates are still not closed. Epiphyseal plates in the bone, they are still active. Now, whenever there is so much amount of growth hormone in children, they will increase in the heights. So, that will cause gigantism. Now, in the adult, because of some pituitary tumor, if they are having too much amount of growth hormone, now in adults, it will cause a condition called as acromegaly. Okay, so acromegaly is due to excessive growth hormone in adults. Now, in an adult, he cannot grow in height. So that what happens? The bones are going to become thicker in size. The body viscera, the body organs, they will increase in the size. Not the length, not the length. They will increase in the size. The person is not going to grow in height. The person's viscera, the liver, the heart, the tongue, all these viscera are becoming bigger and bigger. So see, now in this image also, you can clearly see that this patient is having frontal bossing. His jaw will come protrude forward. That is called as a prognathism. If you look at his tongue, he is having beefy tongue, which is simply dangling outside his mouth. So there is a bigger tongue is there, the big tongue is there, which is called as a macroglossia. Macroglossia means bigger tongue. He is having prognathism. The jaw is protruding forward. He is having frontal bossing. Okay, all if you look at his all body viscera, they are very, very big. Now, whenever you look at his, the hand, it will be very, very big. Okay, very, very big. So these are the features which are seen in a patient who is suffering with acromegaly. Now, simple opposite thing. Whenever there is a deficiency of growth hormone, no growth hormone is there. Now, whenever there is no growth hormone, do you think the person is going to increase in its height? In his height? Definitely not. So the person is going to suffer with dwarfism. Dwarfism. The person is not growing in the height. This baby, the children, is not growing in the height. So that will cause dwarfism. Now, important point which I want you to know is there is something called as the lower end dwarfism. So, what is lower end dwarfism, sir? Normally, just talk about the normal dwarfism. Normal dwarfism means there is no growth hormone, so that there is no growth. What is Laurent dwarfism or Levy-Laurent dwarfism? So there is growth hormone, no doubt. There is no doubt growth hormone is there. But this growth hormone, it's not either getting converted into somatomedian C. Okay, it's not getting converted into somatomedian C. Why? Because the growth hormone receptors are defective. There is a defective in the growth hormone receptors. So the growth hormone is not getting converted into somatomedian C. Now, what happened to somatomedian C levels are insulin-like growth factor levels. The insulin-like growth factor, ILGF, insulin-like growth factor levels are going down. Now, whenever there is no insulin-like growth factor, what happens? Do you think the indirect way of bone growth will happen? No, sir. So bone growth is not happening. The growth hormone receptors are defective. Growth hormone is there, but receptor level there is a mutation. Receptors are defective. So growth hormone cannot stimulate its receptor. So growth cannot happen. So there is growth hormone, but growth is not there. Growth hormone is there, but growth is not there. So this type of dwarfism is called as the Laurent dwarfism. Especially here, the diagnostic thing is the ILGF levels or the somatomedian C levels are very, very low. Okay, very, very low. Guys, let's take a small break of 5 minutes. Okay, let's take a very small break of 5 minutes. Now, let's continue with the other hormones which you need to know. Okay, we have discussed about the growth hormone. Now, after the class, after the break, now let's discuss about some important points about thyroid hormone, cortisol. Okay, and other hormones like parathyroid hormone, insulin. We will discuss after the break. Have a break for 5 minutes. See you in 5 minutes. Okay. Guys, now after discussing about the growth hormone, now quickly let's discuss about a few important points about the prolactin. Okay, already we have discussed about the prolactin, but just a recap. Sir, prolactin is coming from which cells? Prolactin and growth hormone, they are coming from the acidophilic cells. True. Prolactin helps in milk production or galactopoiesis. Now, prolactin, the new point which I want you to know here, sir, prolactin, it will cause lactational amenorrhea. What exactly is this lactational amenorrhea, sir? Now, prolactin, it's coming, right? It's helping in the milk production. The same prolactin will downregulate FSH, it will downregulate LH. Now, whenever there is no FSH and whenever there is no LH, there is no menstruation. That is the reason why a female who have just delivered the baby, a mother who have just delivered the baby, now immediately after delivering the baby, do you think that this female is again going to start her menses? No. So, after giving birth, for the next 6 months or 7 months or sometime up to 1 year, she is not going to have her menses. Why? Why? Because in this period, she is lactating the child, she is breastfeeding the child. So, in her body, prolactin is there. Now, this prolactin will inhibit FSH, will inhibit the LH, so that there is no follicle developing and there is no ovulation. So, that is known as lactational amenorrhea. During lactation period, the female is having amenorrhea, sir. Okay. Now, what exactly is the antagonistic hormone? The prolactin inhibitory hormone is dopamine, which will decrease the levels of prolactin. We know this. Now, next question is, sir, when do prolactin increases? Already I have explained this one thing to you. Sir, during REM sleep, prolactin levels are increased. But not only during REM sleep, there are other conditions where prolactin levels increases. During pregnancy. So, most of the students, they will think like this. So, after delivery, the female will give breastfeeding. So, during breastfeeding, there will be more prolactin levels. The students will think like this. But no, sir. Prolactin levels are seen to be maximum during pregnancy, not during breastfeeding. Yes, of course, during breastfeeding, prolactin levels are more, but the maximum prolactin levels are seen during pregnancy. And 24 hours after delivery, prolactin levels are more. True. During lactation, prolactin levels are more, and prolactin levels are also going to be more during intercourse, sexual activity. But remember, maximum prolactin levels are not seen during lactation. Maximum prolactin levels are seen during pregnancy. Don't forget it. Now, let's talk about a condition called as a prolactinoma. What exactly is prolactinoma? Tumor of lactotropes. Tumor of lactotropes, which are usually small tumors, which are examples of microadenomas. These are not cancers. They are just adenomas, tumors. Small tumors, which are less than 10 millimeter in size. Small tumors. Now, whenever a female is having prolactinoma, what will happen? These are functional tumors. Functional tumors means they are actively producing prolactin. So, what happened to prolactin level? Prolactin level increases. Now, whenever prolactin levels is increasing in this female, now definitely this prolactin will inhibit FSH and LH. So that the female is now having amenorrhea. A female with prolactinoma, she will suffer with amenorrhea. No cycles, no menstrual cycles are there. And she start to have milk production. A 15-year-old girl or 20-year-old girl who have a tumor in her pituitary gland. Now this 15-year-old girl is now secreting the milk from her breast. So this is the galactorrhea, sir. Not normal milk production, galactorrhea, abnormal before pregnancy. Okay, and she is also going to have, like, if this same thing happens in man, if the man is having the prolactinoma, now this fellow is going to suffer with the gynecomastia. There is increase in the size of the breast in the male, gynecomastia. Now, important point which I want you to know is, see, sir, please concentrate here. Here, there is prolactinoma. Here is pituitary tumor. This is the pituitary tumor. Now, this pituitary tumor, what exactly is doing? It is enlarging in size so that, see, it is actually compressing the optic chiasma. In this area, actually, optic chiasma will be there. Okay, in this area, actually, optic chiasma will be there. Now, optic chiasma is getting compressed. Optic chiasma is getting damaged. So, whenever optic chiasma damages, this person will have now visual abnormalities. Which type of visual abnormalities? The visual abnormality this patient is going to have is called as a bitemporal hemianopsia. Bitemporal hemianopsia. Okay, bitemporal hemianopsia means the person is going to lose the vision. The person is going to lose his vision, especially on the temporal sides. Okay, especially on the temporal sides. Why especially on the temporal sides? That's a total different topic. You need to know what are exactly the nasal retinal fibers, the temporal retinal fibers, now which fibers are crossing in the optic chiasma. That's a total different topic. But here what I want you to understand is, sir, this tumor will compress the optic chiasm so that retinal fibers are damaged. The patient is going to lose the vision, especially on the temporal sides. Okay. So the topic of prolactin. Normal prolactin is done. Now let's talk about a clinical link. So now how to treat this prolactinoma? How to treat the symptoms of prolactinoma? The definitive treatment is all the time surgery. Okay, if it is a big tumor, if it is causing a lot of symptoms, definitely the person have to go for the surgery. But how to decrease the clinical features? For example, like galactorrhea, okay, headache, those clinical features. So prolactinoma, here there is so much amount of prolactin. Now we know prolactin antagonistic hormone is dopamine. So the treatment is done with dopaminergic drugs or dopamine agonistic drugs. What are the dopamine-like drugs or dopamine agonistic drugs? Drugs include cabergoline and bromocriptine. So cabergoline and bromocriptine, they are used in the treatment of prolactinoma to decrease the symptoms. Okay, to decrease the symptoms. Now after discussing about the prolactin, now the very important hormone we are going to discuss, which is thyroid hormone. Thyroid hormone. Before discussing about the thyroid hormone, now let's have a brief, okay, understanding how exactly the thyroid gland will be and which cells will be there in the thyroid gland. So here I am showing you a thyroid gland, a simple diagram of thyroid gland. Inside the thyroid gland, I am showing you these green colors, green color cells. Now what are those green color cells called as? The green color cells which I have shown you here, they are the follicular cells. Please concentrate here, they are the follicular cells. Now what do these follicular cells produce? They produce the T4, they produce T4 and T3. Okay, thyroid hormones T4 and T3 are produced from the follicular cells. Now apart from follicular cells, I have also shown you here these white color cells. Now what exactly are these white color cells? So these white color cells are called as the parafollicular cells. Now what do these parafollicular cells will do? They will produce the hormone called as calcitonin. Now what do this calcitonin will do? Calcitonin decreases the blood calcium levels. But who increases the blood calcium levels? Parathyroid hormone. Parathyroid hormone, vitamin D, increases the blood calcium levels. But who decreases the blood calcium levels? Calcitonin. Calcitonin decreases the blood calcium levels. Okay. Now, having said that, let's discuss about how actually the thyroid hormones are getting produced. Okay. Now, please see here, if I zoom into the follicular cells, you can actually see there is an area called as a colloid. In the colloid, the T3 and T4 hormones are present. Now, how actually these T3, T4 hormones are produced? Now we will discuss. Okay. Now we will discuss. Here, I have shown you the blood vessel. Okay, I have shown you the blood vessel. Now the person have eaten some food. Now definitely, let's take it as a seafood. Now in the seafood, which is especially rich in iodine. Now the person have taken some iodine rich food or the iodide rich salt. Now these iodides have entered into the body. Iodides have entered into the body. Now the raw material for the preparation of T3, T4 is iodide. Don't forget the raw material, this iodide ions are the raw materials. So these follicular cells which I am showing you, this is actually a follicular cell. Now these follicular cells, they have to capture this iodide ion for the production of T3, T4. Now for that, see, there is an important transporter present here. What is the name of the transporter? Sodium iodide symporter. So the sodium iodide symporter, with the help of the sodium iodide symporter, the iodine is being uptaken into where? The iodine is being uptaken into the cell, sir, into the cell. Now iodine came into the cell. Okay, let's stop here. Now let's see what is happening on the other end of the story. So these follicular cells, okay, these follicular cells, now they are actually making a protein. Okay, they are actually synthesizing a protein. So the name of this protein is called as a thyroglobulin. Thyroglobulin is a protein which is getting produced from the follicular cells. Now, if you see this thyroglobulin, it's having lots of these amino acid residues. What is this amino acid which I am showing you here? It's a tyrosin. So tyrosin is the amino acid which is rich in quantities in the thyroglobulin. Okay. Now what is done? The two raw materials, we have taken up the iodine and also we have made thyroglobulins. So iodine is there, iodide ions are there, thyroglobulin is there. Now by mixing them, we are going to make the T3, T4. Now what happens? Now step by step, there are actually three important steps. Now see what are they. Now these iodide ions which came into the cell, now it's having a negative charge. This is very bad. We don't want to have these negative charges. Negative is bad. Now what happens is, so these iodide ions, now they are going to enter into a region called as a colloid. Okay, now there is a region. See, I have already shown you what exactly is colloid. The center of the follicular cells is called as a colloid. Now, this iodide ion, it will go into the colloid with the help of a transporter. This transporter which I have shown you, that white color transporter. The transporter name is called as a pendrin. So, with the help of a transporter called as a pendrin, this iodide ions, they have entered into the colloid. Now, what happens? Now, we have to take out that negative charge. Okay, we have to take out that negative charge. Now, the negative charge, it will be neutralized with the help of a process called as oxidation. The first process, the first step is oxidation. What exactly is oxidation? We are taking out the negative charge. Oxidation. We are taking out the negative charge. Oxidation. Now, this oxidation is done with the help of an enzyme called as thyroid peroxidase, TPO. This is the first step. So, what is the first step in the thyroid hormone synthesis, T3, T4 synthesis? Oxidation. Now, okay, we are having this iodide here. Now, what will happen is, see, these are inorganic things, right? Iodide, phosphate, sodium, calcium, magnesium, all these are inorganic things. They are not organic. They are not biological. They are inorganic. They are chemicals. They are totally with the chemistry, right? Now, what we have to do? We are dealing with the biology. So, this iodide, this I need to be incorporated onto a protein. We have to do organification. So, this iodide ions are going to come and sit on our protein. See, this thyroglobulin protein, it also came into the colloid. Now, what happens is, now these iodide ions are being incorporated onto the thyroglobulin. So, iodine is getting organified. We are keeping it onto the thyroglobulin. So, this process is called as organification. Now, this organification is done by which enzyme? Again, same, thyroid peroxidase. Now, what we are left with? At the end of the day, we are left something like this. So, here is our thyroglobulin molecule. Now, it is having one iodide ion. Now, this thyroglobulin molecule with the one iodide ion is called as monoidothyronine. MIT means only one iodide ion is there. But sometimes we can also have a thyroglobulin molecule with the two iodide ions. Yes, it is possible. Onto one thyroglobulin, yes, you can have two iodide ions. So, this is called as diidothyronine, DIT. Okay, diidothyronine, monoidothyronine. Now, what will happen, sir? See, the last reaction which will be done by the thyroid peroxidase is, now it will come and it will couple the monoidothyronine and diidothyronine. Now, marriage is happening. Now, they are coupling. So, the monoidothyronine molecule is going to be coupled with the diidothyronine. So, what do we have? See, one iodine, second iodine and third iodine. So, it is T3, triidothyronine is formed. Now, if you fuse diidothyronine, one diidothyronine molecule with the other diidothyronine molecule, if you couple them, so two DITs, if they couple them, how many iodides do you have? 1, 2, 3, 4. See here, this is one. This is first iodine, second, third, 4. So, 4 iodine molecules are there. This is called as tetraidothyronine, or also called as thyroxine. So, this is how T3 and T4 are formed, and the last step, it's a coupling reaction. It's a coupling. Now, coupling is also done by which enzyme? Thyroid peroxidase. So, first step is oxidation. Second step, organification, and the third step, coupling reaction. So, oxidation, organification, coupling reaction, all are controlled by an enzyme called as thyroid peroxidase, which is very, very important. Okay, at the end of the day, you have T3 and T4. Where do this T3 and T4 are produced? They are produced in the colloid, and they are also stored in the colloid. Once if you have T3 and T4, you can store them for almost 2 to 3 months. You can store these hormones for almost 2 to 3 months. Now, let's talk about some important clinical points which you need to know. See, thyroid peroxidase, MCQs. These are the questions which will come in an exam. So, thyroid peroxidase, it's helping in which process? Oxidation, organification, coupling. True. But there are some people, some individuals, where by birth itself this thyroid peroxidase is deficient. No thyroid peroxidase, TPO deficiency. That will cause a syndrome called as Pendred syndrome. So, what exactly is Pendred syndrome? It's a congenital deficiency of thyroid peroxidase. So, there is no T3, T4. So, by birth itself, this patient is having hypothyroidism, congenital hypothyroidism, as well as these patients will also have sensorineural hearing loss. So, they will ask you in your exams, So what exactly is Pendred syndrome and which kind of clinical features will be there in Pendred syndrome? So Pendred syndrome is a condition where there is congenital deficiency of thyroid peroxidase. Our patient is hypothyroid by birth itself. So congenital hypothyroidism is there. Along with that, these patients will also have sensory neural hearing loss. Okay, why there is sensory neural hearing loss? That's a total topic of ENT. I am not going to go into that way. Our topic is thyroid hormones. So Pendred syndrome is a condition where there is congenital hypothyroidism. Okay. Now, after discussing this, let's talk about a few important effects which you need to know. Sir, what exactly is Wolff-Chaikoff effect? Have you ever heard about Wolff-Chaikoff effect? Guys, I'm asking you. Okay, I'm asking you. Meenakshi, have you ever heard about Meenakshi, Mughal? Okay, have you ever heard about Wolff-Chaikoff effect? Wolff-Chaikoff effect. And why do that effect is more important, especially as a surgeon, you need to know what exactly is this Wolff-Chaikoff effect. Anyone? So what exactly is it? So whenever you give iodine, okay, whenever you give iodine in high quantities, that will actually decreases the size of the thyroid gland. That will actually decreases the blood flow to the thyroid gland. So there will be decrease in the T3, T4 hormone production. So what exactly is Wolff-Chaikoff effect? Wolff-Chaikoff effect is whenever you load the iodine, whenever you give lots of iodine to the thyroid gland, now thyroid gland stop functioning. Okay, so it's very simple. Whenever you give little iodine every day, it's functioning good. But whenever you give lots of iodine continuously, what happens? It stops function. Thyroid glands will become small in size. The blood supply to the thyroid gland will decrease. This effect is called as Wolff-Chaikoff effect. So how to understand this, sir? For example, right now I'm working. We are all working for the money. But whenever you give me $1 million, or whenever I give you $1 million, do you think you will work from today? Do you think you are going to work from tomorrow? Or just the moment you get the money, you will simply feel like I'm not going to work. I'm just going to simply enjoy. You are not going to work. In the same way, whenever you give little iodine every time, thyroid gland is working fine. But whenever you load the thyroid with lots of iodine, thyroid stops functioning. This effect is called as a Wolff-Chaikoff effect. But I just don't want you to know just this simple thing. Why this is important? How this is clinically relevant for us as a doctor? Now, let's take up a hypothetical scenario. Imagine that there was this one person. Okay, there was this one person. Now, this person is having goiter. Okay, this person is having a goiter. Okay, he's having a big tumor. He's having a big tumor in his thyroid gland. Okay, now there was this one sad fellow who is having a big tumor in his thyroid gland. Now, you came to know, okay, there is this tumor and you just want to operate this tumor. Okay, you want to operate this tumor. Now, my question is, sir, here there is a lot of T3, T4. In the thyroid gland, there is a lot of T3, T4. Now, what you have done is, now you just took this patient to surgery. Now, this patient was lying like this. Okay, this patient was lying like this, and here is his thyroid gland with the tumor. Now, what you are doing is you are doing surgery to this patient. Now, while you are trying to remove this thyroid, tumor, while you are trying to remove this adenoma, you might accidentally end up filling the T3, T4 which was already here. Here there is lots of T3, T4. There is lots of T3, T4 which is there. Now, the T3, T4 during surgery, you might damage to the tumor, you might damage to the adenoma, so the T3, T4 are entering into the systemic circulation. Now, what happened? Suddenly, at a time, there is a spike in T3, T4. Now, this T3, T4 will go to the heart, increases the heart rate, increases the BP, increases the body temperature of this person, so that this person can die with a tachycardia on the table itself. On the surgical table itself, he is going to die. So how to avoid this condition? Actually, the condition whichever I have discussed with you right now, that condition is called as a thyrotoxicosis. Okay, it's called as thyrotoxicosis. Thyrotoxicosis means a sudden increase in T3, T4 causing rapid symptoms, dangerously dangerous symptoms. So this is thyrotoxicosis. Now, how to avoid this thyrotoxicosis? Now, don't take this person immediately to surgery. Okay, you have identified there is a tumor, but don't take this person to surgery. So what you have to do? Ask this person to take Lugol's iodine. Give this person Lugol's iodine for the next 1 month. Okay, usually we will give for 10 days, but theoretically, okay, we have to give Lugol's iodine for the 1 month. Now, what effect is going to come into play? Wolff-Chaikoff effect, sir. Whenever you are giving iodine, what happens? Continuously iodine, iodine, iodine. Now, thyroid gland stop functioning. Now, T3, T4, whatever is there inside the thyroid gland, T3, T4 levels decreases. Also, I have explained you what happened to the vascularity of the thyroid gland. The blood supply to the thyroid gland decreases. So, thyroid glands become small in size. So, it will be very easily operated. You can easily operate the thyroid gland during surgery. And the blood loss will be minimalistic. Why? Because blood vasculature, the blood supply got down. The vascularity got down. So, during thyroid surgery, the amount of blood loss is going to come down. Okay, so this is the importance of Wolff-Chaikoff effect. So what exactly is Wolff-Chaikoff effect? Again, just see here, giving glucose iodine to the patient leads to a transient decrease, a transient inhibition of thyroid hormone production. Organification, especially the organification step is going to be inhibited. Whenever there is no organification, there is no T3 and no T4. Whenever there is no T3, T4, you can avoid thyrotoxicosis. Okay. Now, so glucose iodine, I have also explained to you, decreases the vascularity of the gland. It also decreases the size of the gland. Okay, Wolff-Chaikoff effect discussed. Now, what exactly is Jod-Besidov effect? Jod-Besidov's effect, exact opposite. So, whenever you use iodine for some diagnostic purpose, which diagnostic purpose? See, there is a scan called as radioactive iodine scan. Okay, radioactive iodine scan. Now, during radioactive iodine scan, what you will do is, you will give radioactive iodine to this patient. The patient is going to take radioactive iodine. All the radioactive iodine is going to come into the thyroid gland. And from the thyroid gland, now this radioactive iodine, it will start to emit the rays. It will start to emit the beta rays. Now, you can actually capture these beta rays and you can have the entire view of thyroid gland. You can see the thyroid gland. Okay, is there is any hot nodule, cold nodule? Is it a single nodule or it's a multiple nodules were there? You can know. There is a scan called as radioactive iodine scan. Simple. But what exactly are you doing? You are giving the person radioactive iodine. You have given radioactive iodine. Now we know, so this is not a continuous iodine. Now you gave it for one time. Now this radioactive iodine is nothing but iodine. Now what this thyroid gland will do? Now it will use this iodine for the production of thyroid hormones. Now, iodine-induced hyperthyroidism, iodine-induced hyperthyroidism is called as Jod-Besidov effect, which is usually seen after radioactive iodine scan. Okay, usually seen after radioactive iodine scan. Now, here there are few important MCQs which I want you to know for your exams. Sir, how many types of radioactive iodine are there? See, there is something called as iodine 131, iodine 131, iodine 123, and iodine 132. All of these are radioactive iodines. But important point is, two important MCQs were there. What is the half-life? Radioactive iodine 131, its half-life is 8 days. The moment you give this radioactive iodine, it will stay in the body for 8 days. So actually, this radioactive iodine 131 is used for treatment purpose. Treatment purpose. Which treatment? You know, you all know about the Graves' disease, right? I think most of the student knows about Graves' disease. The patient is suffering with hyperthyroidism. Hyperthyroidism. So now, how to treat this condition of Graves' disease? Give this person iodine 131. The moment you give iodine 131, this iodine 131 will go and it stays in the thyroid gland for 8 days. It emits radiation. It will kill the thyroid tissue. So hyperthyroidism is treated. So usually, know this point, iodine 131 is going to stay in the body for 8 days. So for this 8 days, you have to isolate this person. You should not let this person to simply move in the public. Radioactivity is there. So simple isolation. The person is in isolation. And radioactive iodine 131 is not used for normal diagnostic purpose. No diagnosis. This is used for therapeutic purpose. Iodine 131 is used for therapeutic purpose, especially to treat Graves' disease. And therapeutic purpose, you use iodine 123. It is going to stay in the body for 12 to 14 hours. This is actually what we use for radioactive iodine scan. Okay, iodine 123, it stays in the body for 12 to 14 hours. So important points I have discussed. So after this, there are two more important terms which you need to know. What exactly is thyrotoxicosis factitia? Thyrotoxicosis factitia, in the name it is there, thyrotoxicosis. T3, T4 elevated, toxic symptoms are there. Thyrotoxicosis factitia. Why? 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 Because see, the thyrotoxicosis is due to excessive intake of thyroid hormones. Okay, excessive intake of thyroid hormones. Now, why do a patient is taking thyroid hormones? Think like this. Normally, a patient, okay, a patient who is actually hypothyroid. Now, what we used to do, how we used to treat them? We will give thyroid tablets every day. We will give thyroxine tablets. But this patient is illiterate patient, okay, or this patient is having amnesia. Now, he took one tablet, but unknowingly, he is again taking excessive tablets that he just simply forgot, and he is taking excessive tablets. Okay, or there is a very important thing which I want to say here. Especially, the thyroid hormones are catabolic hormones. Whenever you take thyroid hormones, you will lose your body weight. So, most of the females, they will use this property, they will abuse this property. Do you know how? Imagine that there was this one female who is a doctor, she knows about thyroid hormones. Now she is almost 100 kilos. Now what she is doing is, now she is taking excessive thyroid hormones to decrease her weight, to cut down her weight. Normally her thyroid gland is making T3, T4, no doubt. But from outside, she is excessively taking T3, T4. She is taking thyroxine tablets. So what this thyroxine will do? Will increases her basal metabolic rate, so that now she will try to lose the weight. Okay, she is losing the weight, but there is excessive T3, T4 in the body. So that will cause thyrotoxicosis factitia. Now she will start to have hyperthyroidism symptoms. Okay. So thyrotoxicosis due to excessive intake of thyroid hormones. Now what exactly is Hamburger's toxicosis? Hamburger's toxicosis is it's a type of thyrotoxicosis factitia. See, the patient, okay, the person is ingesting the thyroid gland of an animal, maybe of a beef or maybe of a sheep. Okay, especially this is seen in the Latin American countries, where they will take a hamburger, they will keep the thyroid gland of an animal, and they will take the burger along with the thyroid gland. Now inside the thyroid gland of an animal, there is T3, T4, active T3, T4 are present, and these active T3, T4, they will enter into the body, they will cross the membranes, and this T3, T4 are going to act on your tissues, so causing symptoms, thyrotoxicosis. So this is called as Hamburger's toxicosis, a type of thyrotoxicosis factitia, taking thyroid hormones from outside, exogenous intake of thyroid hormones. Okay, so I have explained to you what exactly is Wilczekov effect, Jod-Besidov effect, thyrotoxicosis factitia, and Hamburger's toxicosis. Is it clear, guys? Do you have any doubts? If you have any doubts, you can all the time put it in the chat box. Just I'm checking. Yeah, animal thyroid gland. Guys, should I continue? Should I go forward? If you have any questions, you can ask me. So, no doubts. Now, let's see some important properties of T3, T4 and what exactly these thyroid hormones are doing to our body. I have already explained to you, sir, growth hormone is the anabolic hormone, but the T3, T4, they are catabolic hormones. Now, why they are called as catabolic hormones? Now, in a minute, we will see. But before that, let's continue with the basic points. So, T3 and T4 are produced. Now, T3, it's coming into the blood. Now, is it traveling freely? No. Okay, most of the T3 is going to bound with which plasma protein? T3 is mainly bound with albumin, but T4 is mainly bound with globulins called as thyroid binding globulins, TBGs. Okay, sir, we all know that T4 and T3 both are produced, but who is active? T3 is the active form, T4 is the inactive form. T4 is in maximum quantity, T3 is in less quantity. T4 have maximum half-life, T3 have less half-life. But right now what is the topic is, so T3 and T4, they are there in the blood. T3 mainly binds with what? So what exactly is Graves' disease? I will explain to you what exactly is Graves' disease. Graves' disease is very simple. Okay, I will explain to you, but let's go with the basic points first. Now T3. What this T3 is doing? So T3 is traveling with albumin in the blood. For example, if you see this is the T3 molecule, it's not actually traveling freely. Most of the T3 is bound with a protein called as albumin. It bonds with albumin, and T4 bonds with globulins, thyroid binding globulins. Okay, but 1% of T3, T4, know this point, 1%, only 1% of T3, T4, they are traveling in free form. Okay, But some amount of T3, T4 and along with vitamin A, they are also bound with something called as transthyretin, not needed for your things, but just what I want you to know is T3 bound with albumin, T4 bound with thyroid binding globulins, 1% is freely traveling in the blood, and that 1% is biologically active. That 1% is the one responsible for showing the effects of thyroid hormones. That 1%, small little percent. Now let's see what is the difference between T3 and T4. Guys, many times the questions will come from this area. T3, it's active or not? T3 is the active form, sir, and T4 is less active form, Now T3, it's having short half-life, only 1 day. T3 is going to be active for 1 day. Later on, it will be degraded. But T4 is going to be there in your blood for almost a week, 6 to 7 days. It will stay in your blood for 6 to 7 days. So T4 is gradually getting converted into T3. T4 is converted into T3. T3 will show you the effects. Now T3, does it give negative feedback? No. Who gives the negative feedback? Negative feedback to the central nervous system. Negative feedback. Whenever you have enough amount of T3 and T4, see the T4 levels will give negative feedback to the central nervous system. Already T4 is there. Thyroid hormones are there. There is no need of TRH, no need of TSH. No need of TRH, no need of TSH. Enough thyroid hormones are there. Right now there is no need of TRH and TSH. Okay, so T4 gives the negative feedback, not the T3. And T3 is less in blood, I have explained to you. Less in blood but more active. But T4 is more in blood but less active. Okay, and who is having fast action? T3 is having fast action, T4 is having slow action, inactive thing. Okay, now what happens, sir? Who is maximum? T4 is maximum. Now what happened? Now, so the T4, whenever it is needed, in the tissues, not in the blood, in the tissues, the T4 is getting converted into T3. T4 is getting into what? It's converting into T3 with the help of an enzyme called as 5' deiodinase. So the T4 is getting converted into T3 with the help of an enzyme called as 5' deiodinase. Now our active form T3 is there, our hero is there, T3. Now what this T3 is doing? The T3 I have already explained to you, it's a catabolic hormone. It destroys everything. Whatever it comes into contact, it will cause a destruction, lipolysis, proteolysis, glycogenolysis, everything lysis. Okay, so T3, what it will do? It will cause, let's start from here. It acts on the lipids, causes lipolysis. Okay, lipids are getting broken down. It acts on proteins, causes proteolysis. Proteins will be broken down. And it decreases the blood levels of cholesterol. Okay, and this thyroid hormone increases the glucose. Now here I just want to take a minute and I want you to know, see, at your basic level, okay, at your basic level, most of the students, what they will think is, sir, insulin decreases the blood glucose. But who increases the blood glucose? If I ask you, you will say, sir, glucose is increased by a hormone called as glucagon. But now here I just want to take an advantage of this endocrine topic. See, glucagon increases the blood glucose levels, no doubt. But I have explained to you, growth hormone also increases the blood glucose levels, no doubt. Now I am saying you, T3 increases the blood glucose levels. Later I will say you, cortisol increases the blood glucose levels. And also epinephrine, norepinephrine increase the blood glucose levels. So don't be in a state that only glucagon will come and increase the blood glucose levels. Not only glucagon, growth hormone increases, thyroid hormone increases, cortisol increases the blood glucose levels, norepinephrine increases the blood glucose levels. There are many hormones which increase the blood glucose levels. Okay, so here also see, right now thyroid hormones, they will cause glycogenolysis, they causes increase in the blood glucose levels, lipolysis, proteolysis. Here important point is, what exactly is this BMR? Most of the students, they will think what exactly is BMR, but they don't know actually. So what is basal metabolic rate? What is basal metabolic rate? In a simple way, try to answer my question. What exactly is basal metabolic rate, sir? Can you tell me? I just don't want the complicated answer. Simple. Basal metabolic rate. If you know, just tell me. Can you tell me what exactly is basal metabolic rate? Come on, guys. Simple explanation. Put it in the chat box. See? Yeah, thyroid hormone increases the metabolism. But let's put it this way. See, I'm just saying to you, sir, my basal metabolic rate is 3000 kilocalories. My basal metabolic rate is 3000 kilocalories. It means to run this body for the next 24 hours, to maintain the homeostasis in this body for the one day, how much calories are required is the basal metabolic rate. My basal metabolic rate is 3000 calories. For example, imagine that there was one female who is not working much. Now her basal metabolic rate, how much calories does she need to maintain the homeostasis in her body? All the metabolic reactions, maintenance of the body temperature, everything, every function. Her basal metabolic rate will be somewhere around 2500 or 2700. So basal metabolic rate is how many calories are needed to keep the entire body in homeostasis for the one day. Now, whenever thyroid hormone increases, the basal metabolic rate increases. Now, how it will increase, we'll discuss in a minute. Don't worry. Okay. Now, thyroid hormones, they are also thermogenic hormones. They increases the body temperature. They maintains the body temperature actually. Okay. Whenever you have more T3 and more T4, the body temperature will be increased. So, one part is completed, one limb is completed. Now, let's see what are the other functions of this T3, T4. Now, the T3 during childhood, it helps in bone growth. Not only the growth hormone, thyroid hormones are must and should for the growth. Now, thyroid hormones are very much important for the development of the synapses, neuronal development, synapses, synapse formation. For synapse formation, you need thyroid hormones. And thyroid hormone acts on the heart, increases the heart rate. How it will increase the heart rate, we will discuss, don't worry. So, in this one slide, I am just giving up all the important functions of thyroid hormone. Now, let's see one by one. Thyroid hormones, I have shown you, thyroid hormones, they are acting on the heart. They are increasing the heart rate. What exactly is this, sir? The statement is very important. See here. See T3, it is acting on the myocardium. Okay, I am taking the heart cell, one myocardial cell, ventricular myocardial cell. We all know on the ventricular myocardial cell, there are sympathetic receptors. Sympathetic nervous system receptors are there. What are the sympathetic nervous system receptors? Beta 1. So, on this myocardial cell, there is beta 1 adrenergic receptor. Okay, beta 1 adrenergic receptor is there. Now, whenever thyroid hormones T3 is coming and acting on the myocardium, now normally there is 3 beta 1 receptors. Here there are 3 beta 1 receptors. Now, whenever T3 comes and acts here, now instead of 3, there will be more beta 1 receptors. More beta 1 receptors will come here. Now, what's happening? Now, this myocardium is becoming more and more sensitive. Now, this myocardium, it is becoming more sensitive to norepinephrine. Now, even a little amount of norepinephrine can stimulate all the receptors, so that this myocardium is stimulated so much so that there will be increase in heart rate. So, what I can say as a statement is that T3 or thyroid hormones, what they are doing? They makes the myocardium sensitive to catecholamines. Whenever there is T3, more adrenergic receptors are going to come onto the myocardium, so that the myocardium become more sensitive to the catecholamines. So, there will be increase in heart rate. There will be increase in heart rate. Now, after this, the important concept what I want you to understand is, sir, how thyroid hormone increases the basal metabolic rate. Normally, what is my basal metabolic rate right now? 3000 kilocalories. But think like this. If I take a thyroxine tablet, I have taken thyroid hormones into my body. Now, instead of 3000 kilocalories, from tomorrow, I will use 3500 kilocalories or 4000 kilocalories. More calories are getting burned out. Calories are getting burned out of my body. I need more calories to run this body. Why, sir? Why? To understand this, see, normally I am just showing you one body cell. Any body cell you can take. This is one body cell. Normally on the surface of body cells, which transporters are present? Every student knows that there is a transporter, sir, which will bring the sodium out, which will take the sodium out of the body. Okay, which will take the sodium out of the body, and this transporter will bring the potassium into the cell. Okay, there is a transporter which will take the sodium out of the cell, throws the potassium into the cell with the help of ATP. What is the name of the transporter? Sodium potassium ATPase. So, sodium potassium ATPase is present on each and every cell in your body. Normally here in this cell, I am showing you 2 sodium potassium ATPases. I am showing you 2 sodium potassium ATPases, sir. Now, let's talk about what our T3 and T4 are doing, especially the T3. Now, the T3, it is entering into the cell. See, it is entering into the cell. Now, after entering into the cell, now what exactly this T3 is doing? Now, the T3 Sir, it can directly enter into the nucleus. It can cross the cell membrane. It can enter into the nucleus. Why? Because the T3 receptors. T3 receptors are present where? The T3 receptors are present inside the nucleus. So very, very important question. Intranuclear receptors are present for which hormone? Thyroid hormone, no doubt. Now what it is doing? Now this T3, it will bind with its receptor. Now it will help in production of, it will cause transcription, translation. So at the end of the day, what I am saying is, at the end of the day, now this is what happens. See, now there is production of more sodium potassium ATPases. Now instead of 2 or 3 sodium potassium ATPases, now on the surface of the cell, see how many sodium potassium ATPases are coming. Now sodium potassium ATPase concentration on the cell membranes are increasing. Now tell me, more the number of sodium potassium ATPases, more ATP are getting broken down. So more calories are getting utilized, more ATP are getting broken down, so more energy is getting utilized. So what happens? Instead of 3000 calories, now more ATP is getting broken down in my body. So that will increases my basal metabolic rate. Whenever the ATP is getting broken down, energy will be released, heat will be released. So thyroid hormones increases the body temperature. So now if someone comes to you and asks you, sir, thyroid hormones increases the basal metabolic rate. How? Thyroid hormones increase the basal metabolic rate by increasing the number of sodium potassium ATPases on the cell surface. So basal metabolic rate increases. This is how the basal metabolic rate is increased. Okay, is it clear? Is it clear, guys? Yeah, beta 1 receptors, someone is asking, Mohammed. Yes, beta 1 receptors are also present on the juxtaglomerular cells. True. Okay, beta 1 receptors are present. Yes, true. On the juxtaglomerular cells, it's there. On the heart, it is there. Okay. Now, after this, let's discuss about a few, one important point, one important exam, especially for your exam. See, sir, hypothyroidism and hypothyroidism. What is the difference between hypothyroidism and hyperthyroidism? In the name itself, it's there. Hypo means less amount of T3, T4. But see, whenever you look at the T3 and T4 level, see here, I'm just showing you T3 and T4 levels in hypothyroidism. Let's first hypothyroidism. Now, what usually students will think is, sir, in hypothyroidism, T3 levels are low, T4 levels are low. Yes, T3, T4 levels are low when in a severe disease. But during initial phases, during subclinical phases, subclinical means initially, the patient is having hypothyroidism, but symptoms are not that much. So initially, the T3 levels are normal, T4 levels are also normal. But if you see about the TSH, what happens during hypothyroidism? There is no T3, T4. So immediately your brain will recognize and your anterior pituitary will release pumps. It will start to pump TSH. So TSH levels are increased. TSH levels are increased in hypothyroidism. And look at the hyperthyroidism. What usually students think is hyperthyroidism, T3 is elevated, T4 is elevated. Yes, true, no doubt. T3 is elevated, T4 is elevated. But in the subclinical phases, T3 is normal, T4 is normal. But when you look at the TSH is decreased. Already you are having enough amount of T3, T4. So that TSH is not getting released. TSH is not coming down. So TSH levels are decreased. Okay, now tell me, so in both hypothyroidism and hyperthyroidism, you cannot rely on T3, T4 values. Why? Because T3, T4 values can be normal also. So what is the most sensitive investigation to rule out hypothyroidism and hyperthyroidism? It is the TSH values, sir, not the T3, T4 values. It is the TSH values, not the T3, T4 values. Okay, guys, I hope up till this point, this is enough for today. Actually, the next topic is all about the hyperthyroidism and hypothyroidism, more clinically integrated, like topics. Now, if I start, we cannot complete the hyperthyroidism and hypothyroidism in the next 15 minutes or 20 minutes. It will take at least half an hour. So it's already 2 hours. Now let's done for today. Okay. Now let's stop till here. We have discussed about the growth hormone and thyroid hormone. Now tomorrow let's discuss about the thyroid hormone abnormalities like hyperthyroidism, hypothyroidism. What are the causes? And after that, let's also discuss about the cortisol. Okay, Cushing syndrome. After that, insulin. And lastly, let's talk about the parathyroid hormone. In tomorrow's class, let's totally wind up the entire endocrine physiology. Hope the class is helpful. If you have any doubts, you can all the time keep it in the chat box, and the entire PPT will be shared with you in the Telegram group. Is it clear, guys? Do you have any doubts? Yeah, definitely. We'll share the Telegram. I think the Telegram group was already, the link was already given with the previous videos. Okay, you just check in the comment box. You just check in the comment box. There the Telegram link was already given. Okay. See you tomorrow, guys. See you tomorrow exactly at the 7 o'clock. Thank you.